So, for instance, you might see a lesion that's moderate and not know whether is this lesion what's causing the problem or not, and place a stent in it. In the most egregious examples, people place stents in lesions that are not significant at all. But more often than not, what I see is that we're confronted with something that may or may not be the source of the problem, and rather than take the time to really evaluate it, we place a stent and move on. The guidelines would suggest it's reasonable to place stents in patients who are having an acute MI, acute myocardial infarction, in the culprit artery. So if you think that artery is responsible for this heart attack, then you should open it. And then other times that it's reasonable to place a stent are when someone's having a lot of chest pain, and you have evidence that this artery that appears either completely or partially blocked is causing this pain. And the patient has been aggressively treated with medicines. In that setting, they've failed medical therapy, they have evidence that this artery is causing the problem, and so it's reasonable to open it. It's not a simple percentage. We use diagnostic tests to provoke the problem and see if that blockage seems to be causing it or not. Some patients have sort of pretty sick arteries all around, and they can have a 70% blockage that's actually causing them symptoms when they get up and move around, and other patients tolerate a 70% blockage very, very well because of their reserve. A lot of judgment.